Hi everyone, welcome to today's lecture. This is the first lecture I've actually given you as part of this module, other than our tutorials or the introductory lecture. So really nice to be back and teaching you a bit about some of the forensic toxicology, moving into the clinical toxicology from next week. Before I begin, I just want to say a massive thank you to everyone involved in the teaching of the analytical and forensic toxicology. This lecture is in place to round off the forensic toxicology, introduce you to some of the treatment options available in poisoning events, and begin getting you thinking more in the clinical mindset before we begin the clinical toxicology lectures beginning next week. Now, before I start this lecture, I just want to let you know that the clinical toxicology lectures are all going to be released in one go. Now, that doesn't mean you only have 1 week to review them. You can review these lectures in your own time over the course of the coming weeks ahead of the exam period. I wanted to release them all together so that you can work through them at your own pace and around your own schedules for other modules as you prepare for exams and complete other assessments. So please do make sure that you set aside time in order to review those. There is 6 lectures in total for the clinical toxicology portion of the module. They are quite intense, there's a lot of information there, and I do recommend that you perform some of the additional reading, so you really are going to have to ensure that you budget time accordingly for that. But that's next week. For this week, we are looking at the role of chemical weaponry and treatment options, as well as some of the underlying forensic toxicology which has been conducted after chemical weaponry attacks. So in today's lecture, we're going to be looking at the general principles of toxicology of the organophosphate nerve agents and management of patients following exposure to such agents. We'll also look at some of the methods of detection and confirmation of nerve agents used in chemical weapon attacks. By the end of today's lecture then, you should be able to compare and contrast the mechanisms of toxicity of nerve agents, as well as describe and evaluate the different treatments that we can use in nerve agent exposure. You should also be able to evaluate the methodology of detection of nerve agents, as well as some of the limitations of this following some recent attacks using these agents. So nerve agents themselves, sometimes called nerve gases, are a class of organic chemicals which disrupt neurotransmission, communication of the nerves. And they exert their effects by blocking acetylcholine esterase at the neuronal synapses. And this enzyme is extremely important as it catalyzes the breakdown of acetylcholine, a neurotransmitter. So these nerve agents or nerve gases stop this enzyme from exerting its effect on acetylcholine. So we're going to be looking at what that actually means and what the symptoms are and just how dangerous this really is for the course of today's lecture. Now, the main nerve agents that we are aware of include things such as sarin and VX, and these are all man-made chemicals which have been manufactured for the purpose of chemical warfare. These agents are known to be present in military stockpiles of several nations, including the United States, and they've become highly topical following the assassination of Kim Jong-nam in 2017 and the assassination attempt here in Salisbury in the UK back in 2018. Additionally, the use of sarin was reported in Syria. So these chemical weapons are a massive area of debate and are worryingly being used all around the world. So a little bit of backstory on some of the assassinations and assassination attempts using these nerve agents. An example being the assassination of Kim Jong-nam, who was the eldest son of the North Korean leader Kim Jong-il, and the half-brother of the current North Korean leader Kim Jong-un. Now, he was attacked in the Kuala Lumpur International Airport in Malaysia with VX nerve agent and died on his way to the hospital being transported from the airport. Now, these agents are extremely deadly. And worryingly, they have been used here in the UK. You may have heard of this previously back in 2018, the Salisbury poisonings and the attack on the Skripals. So at 4:15 on March 4th of 2018, Sergei Skripal, a former Russian military intelligence officer and MI6 agent, and his daughter Yulia were found unconscious in a park bench in Salisbury. Eyewitnesses claim that Yulia was foaming at the mouth and her eyes were wide open but entirely white. At 5:10, they were taken separately to the Salisbury District Hospital by an ambulance and an air ambulance. And they received treatment for a presumed nerve agent exposure due to the perceived toxidrome. Now, toxidromes are something that we're going to look at in much more detail in the clinical toxicology lectures of this module, but briefly, a toxidrome is the physical examination of a patient allowing for stratification into broad toxic syndromes. So it's a collection of physical symptoms that we can see in patients that indicate potential poisoning events. So it is a toxic syndrome, a toxidrome. And these, as I say, are a collection of signs and symptoms when viewed together that help us try and figure out a certain class of chemicals that may be responsible for the poisoning event. And we'll look at these in more detail in the clinical toxicology lectures, as I say, but just as an example, these are some toxidromes that can help us work out whether a patient has an opioid or an ethanol overdose. Now, both of these drugs result in decreased consciousness, but they have different effects on the pupils. So opioids cause constricted pupils, whereas ethanol can have variable effects on pupils. As a result, if you have a patient with decreased consciousness and constricted pupils, it may very well be that they have been poisoned with opioids or they've overdosed on opioids. So this is what I mean by a collection of symptoms helping somewhat inform the potential cause of poisoning. And this is known as a toxidrome. And we're going to look at the nerve agent toxidromes today and toxidromes more broadly in the clinical toxicology lectures. Now, a major incident was declared in Salisbury at 9:03 on March 5th, the day after, following Detective Sergeant Nick Bailey, who had been to the Skripals' house, then went on to develop symptoms matching those of the Skripals. Health authorities then checked 48 members of the emergency service and the public for possible syndromes, and 2 further police officers were treated for minor symptoms, which were said to be itching eyes and wheezing, difficulty breathing. A few days after this, it was reported that biological samplings of the Skripals confirmed the presence of a compound or a family of compounds known as Novichok. Now, Novichok, which is Russian for newcomer, novice, or newbie, is a class of very potent nerve agents, and these were developed by the Russian nerve agent program called Foliant. It then took up to a month before scientists at the Organization for the Prohibition of Chemical Weapons, or OPCW, confirmed independently the presence of Novichok in samples from the Skripals and sites across Salisbury. Now, thankfully, Detective Sergeant Nick Bailey was discharged from hospital on the 22nd of March. Yulia Skripal was then discharged on the 9th of April, and Sergei Skripal discharged on the 18th of May. So all 3 of those treated for Novichok exposure thankfully did survive the Salisbury poisoning event. However, 3 months later, in June of 2018, Novichok reappeared in Salisbury after Nick Rowley found a perfume bottle in a bin in Salisbury and then gave it to Dawn Sturgis, who sprayed it on her wrist. Dawn unfortunately fell ill within 15 minutes following spraying the suspected perfume on her wrist, and unfortunately died on the 8th of July. Charlie Riley, who had come into contact with the poison, thankfully survived, but it's believed that this incident was a result of the way that the nerve agent was disposed of after the poisoning in Salisbury. So the theory is that the Novichok agent was transported in this perfume bottle, sprayed on the door handle of the Skripal's house, which is how Nick Bailey then came into contact with it, as well as Yulia and Sergei. And ultimately then that bottle was discarded in a bin, which Charlie Riley then found a few months later and gave it to Dawn Sturgis, who unfortunately lost her life as a result of Novichok poisoning. So we're not going to look too much more at the actual events that followed the Salisbury poisonings, such as the legal trial, and ultimately the reason we're not doing that is because it starts to just get so extreme. It starts to sound like a conspiracy theory ultimately then saying that Vladimir Putin had ordered the assassination of Sergei Skripal. Instead, what we're going to do is look a bit more at Novichok and related compounds and how they have their toxic effects, and ultimately how we treat that, how we manage that in patients, and how we detect if patients have been exposed to these compounds. Now, Novichok agents were developed at a state chemical research institute, which was initially funded by the Soviet Union, which became Russia, between the years of 1971 and 1993. Now, we are aware of 3 Novichok compounds. That, in saying that, there may be other compounds that we just simply don't know of. Novichok compounds that we do know of, though, include substance 33, A230, and A232. And these have all been developed using an organophosphate structural backbone. And due to our understanding of organophosphate poisoning, we use organophosphates, things such as pesticides, so we know what happens when people take or accidentally take organophosphates and how they present following a poisoning event. Because of how we know organophosphates work, the medical team at Salisbury District Hospital were able to identify the toxidrome of the Skripals and Detective Sergeant Nick Bailey and treat them accordingly. Now, the lethal dose of 50% or LD50 of Novichok agents is reportedly just 0.22 micrograms per kilogram. So these are extremely potent, extremely deadly compounds. As I said, the medical team were able to identify the toxidrome of organophosphate poisoning in the Skripals and Nick Bailey and ultimately then administer therapy to suit that toxidrome. And this is because we know how organophosphates produce their toxic effects, and Novichok agents act in a very similar way to the organophosphates, as they're based off that organophosphate structural backbone. Organophosphates actually are used for a number of diverse purposes. We can use them for insecticides, herbicides. We can unfortunately use them as nerve agents, and ultimately they can be used as things like flame retardants. And organophosphate pesticides and nerve agents act in the exact same way by inhibiting the enzyme acetylcholinesterase. Organophosphate products are frequently used, unfortunately, for self-poisoning events with the idea of them being taken in order to commit suicide. And it's a very important public health issue in some developing countries where these are available in more rural areas because they are kept for their pesticide and herbicide uses. In fact, organophosphate poisoning accounts for more than 200,000 deaths every year in some developing countries. So they are a massive global health concern. And because of how we know they produce their toxic effects and their symptoms associated with organophosphate poisoning, we have a very clear toxidrome of organophosphate poisoning, which helped the medical team at the Salisbury District Hospital ultimately identify that the Skripals and Nick Bailey were presenting with organophosphate poisoning, which was later found to be a direct Novichok nerve agent. Now, in order for us to understand how nerve agents and organophosphates actually produce their toxic effects, we have to understand what happens under normal physiological circumstances. What we have here is a nerve terminal, so communication between one nerve and another. And we can see that we've got some acetylcholine receptors here. And we have a synapse, and the synapse is the junction between the presynaptic nerve and the postsynaptic nerve. So the presynaptic nerve, funnily enough, is before the synapse, before that gap between the two neurons, and the postsynaptic nerve is the one after that gap between the two neurons, and that gap is referred to as the synapse. Hopefully that is not new information for you. What happens then is neurotransmitters are released from the presynaptic nerve into the synapse. That then binds to receptors on the postsynaptic neuron and produces a signal, an action potential in that cell. Now, in order to prevent uncontrolled nerve firing, we have enzymes that break down those neurotransmitters. Otherwise, once that signal is switched on, it would remain on and keep firing and keep firing and keep firing. And we would end up with uncontrolled neurotransmission. So we have enzymes which come in and break down those neurotransmitters. In this case, we have the acetylcholine esterase, which breaks down acetylcholine, preventing it from binding to acetylcholine receptors and switching off that signal in the postsynaptic nerve. Now, organophosphates bind to and irreversibly inhibit acetylcholine esterase. What this means is that once acetylcholine is released from the presynaptic nerve into the synapse, it can bind to acetylcholine receptors in the postsynaptic nerve and activate that signal. However, the acetylcholine esterase is no longer able to break down acetylcholine, and so that can build up and generate prolonged and sustained signaling in the postsynaptic nerve. That control, which we previously had between the nerves, is lost, and we end up with uncontrolled neurotransmission. Importantly, there are two different types of acetylcholine receptors, or cholinergic receptors. We have the muscarinic acetylcholine receptor and the nicotinic acetylcholine receptor. And activation of these receptors result in different organophosphate poisoning symptoms. But both of these, importantly, are activated by acetylcholine and so are regulated by the breakdown of acetylcholine by acetylcholine esterase, that enzyme which essentially switches off the nerve signal. So let's look in a bit more detail at these two different types of cholinergic receptors. First, the muscarinic acetylcholine receptor. These are G-protein coupled receptors, which you should recall from PM-261, your Introduction to Pharmacology module, with Prof. Wallace and Dr. Healy. These are 7 transmembrane proteins which are, funnily enough, coupled to a G protein. And they are referred to as muscarinic acetylcholine receptors because they were originally discovered by activating these receptors with muscarine, which is a natural product found within certain types of mushrooms. Importantly, we do not make muscarine in our bodies endogenously. They are activated by acetylcholine. However, in research settings, we discovered them by activating them with muscarine, which closely resembles the acetylcholine, so can activate these receptors. As a result, they were referred to as the muscarinic acetylcholine receptors. So a subclass, one of the two types of the cholinergic receptors, which binds to acetylcholine endogenously. And they act through G proteins to activate downstream signaling events. So acetylcholine binds to the muscarinic acetylcholine receptors, and the G protein then dissociates from the G protein coupled receptor and will trigger a number of downstream signaling events. Now, as these receptors initiate a number of metabolic steps to modulate cell activity, they are referred to as a metabotropic receptor. There's a number of downstream signaling events which must occur, and so they tend to take a little bit longer than the nicotinic acetylcholine receptors, and we're going to compare with them in just a second. But they activate a number of metabolic steps to modulate cell activity. And so the muscarinic acetylcholine receptors belong to a class of receptors known as metabotropic receptors. Conversely then, we have the nicotinic acetylcholine receptors, and these are actually ligand-gated ion channels. And these were originally discovered by activating them with nicotine, so the natural product found within certain plants, such as tobacco. So we do not produce nicotine endogenously within our body, but we would just discovered them in the lab setting by activating these acetylcholine receptors with nicotine. So very similar to the muscarinic acetylcholine receptors, in the sense that they were found to be activated by different compounds, but both of these are endogenously activated by acetylcholine, but they can be exogenously activated by compounds such as nicotine or muscarine. Additionally, nicotine will not activate muscarinic acetylcholine receptors, and muscarine will not activate nicotinic acetylcholine receptors. Acetylcholine can activate both of them, both nicotinic and muscarinic acetylcholine receptors. Now, these act differently from the muscarinic acetylcholine receptors in the sense that they are not G protein coupled receptors. They are ligand gated ion channels. And activation by acetylcholine actually opens the ion channel and allows ions to flow through that ion channel. So there is no metabolic steps involved with this. There is not the need for a G protein coupled or G protein to dissociate from the receptor and activate downstream signaling events. Activation of this receptor results in instantaneous opening of an ion channel. So these nicotinic acetylcholine receptors are not referred to as metabotropic receptors. Instead, they are ionotropic. They immediately result in ion flow through and across the membrane. Now, the nicotinic acetylcholine receptors, which, as I say, can in a research setting be activated by nicotine, but are endogenously within our own bodies activated by acetylcholine, are actually extremely important in controlling muscle fibers. At the neuromuscular junction, the nicotinic acetylcholine receptors are the primary receptor in muscles for nerve-to-muscle communication. So it's actually the nicotinic acetylcholine receptors that allow our nerves to communicate with our muscle fibers. And this synapse between the neurons and the muscle is known as a neuromuscular synapse. So slightly different from a synapse between two neurons, because instead this is then synapsing with a muscle fiber. And the nicotinic acetylcholine receptors are present at the synapse between that neuron and muscle fiber. And as I say, it's called the neuromuscular synapse, and the activation of the nicotinic acetylcholine receptors results in muscle twitching. Now, acetylcholine accumulation in the synapse due to inhibition of acetylcholinesterase, that enzyme which is responsible for breaking down acetylcholine in the synapse to prevent prolonged or sustained signaling, can actually produce different effects depending on whether that accumulation of acetylcholine is sustained activation of the nicotinic acetylcholine receptors, so these ionotropic receptors which directly activate ion channels and allow ion flows and are responsible for muscle contractions at the neuromuscular junctions. Or there can be a different set of effects if the acetylcholinesterase is being inhibited, and so acetylcholine is building up and primarily activating the muscarinic acetylcholine receptors. So these G protein coupled receptors, which are metabotropic, and they must activate G proteins to activate a number of downstream signaling events. So the actual symptoms that patients present with will result either or because of activation of nicotinic acetylcholine receptors and or the muscarinic acetylcholine receptors. The nicotinic manifestations include muscular twitching, cramps, paralysis, hypertension, which is an increase in blood pressure, and tachycardia, which is an increase in the heart rate. And these all result due to that role at the neuromuscular junction of the nicotinic acetylcholine receptors. The muscarinic manifestations, so that buildup of acetylcholine in synapses, which then bind to the muscarinic acetylcholine receptors, these G protein coupled receptors activated by acetylcholine, results in a different set of symptoms. This includes an increase in salivation, an increase in lacrimation, urination, defecation, GI disturbances, and emesis, or vomiting. And this means that we have a lovely acronym to associate with muscarinic manifestations, known as SLUDGE: salivation, lacrimation, urination, defecation, GI disturbances, and emesis. And this is actually the key toxidrome in organophosphate or nerve agent poisoning, and would have likely been used by the clinical team at the Salisbury District Hospital to identify organophosphate poisoning in the Skripals and Nick Bailey. Now, treatment regimes for organophosphate poisoning are twofold. The first needs to have direct decontamination, and this is to prevent further exposure to the patient or medical staff to these deadly organophosphates. So this includes obviously the removal of clothing exposed to organophosphates or nerve agents, as these can then emit trapped vapors or allow contact of organophosphates either further contact to the person that's already been exposed or to the medical staff. So there must be direct decontamination and removal of the source of that organophosphate. The next step then is the administration of pharmacotherapy, so using pharmacological intervention to treat the organophosphate poisoning. And we have a threefold method in order to treat organophosphate poisoning, which can be used not just for organophosphate pesticide poisoning, but for poisoning with organophosphate nerve agents. So things like VX or sarin, and in this case, Novichok. And these treatments include atropine, the oxim drugs, and diazepam. Now, due to the overlapping mechanism of action of organophosphates and nerve agents such as Novichok, these treatment regimes are identical. So both the organophosphates and nerve agents inhibit acetylcholinesterase, prevent the breakdown of acetylcholine, which means that acetylcholine builds up in the synapse and will produce nicotinic effects. So those are muscle related effects, so paralysis, muscle cramps, tachycardia, whereas we'll then have the muscarinic effects, which is sludge symptoms. That's the toxidrome. But both of these can be treated using atropine, oxims, and diazepam. Atropine is used in the treatment of organophosphate and nerve agent poisoning, but it can also be used as a prescription medication to treat symptoms of low heart rate, so bradycardia rather than tachycardia, and to decrease salivation and bronchial secretions before surgery. It's also used in the treatment of overdosing on cholinergic drugs, as well as mushroom poisoning. Atropine itself comes from the belladonna plant, or the deadly nightshade plant. And atropine acts to indirectly counter the effects of organophosphates or nerve agents during a poisoning event. Atropine is a muscarinic acetylcholine receptor antagonist, so it blocks the action of acetylcholine at these receptors. Now, atropine will only counteract the sludge symptoms and not the nicotinic symptoms. So it will bind to the muscarinic acetylcholine receptor. It will prevent acetylcholine binding to and activating that receptor, and therefore it reduces the sludge symptoms, which is salivation, lacrimation, urination, defecation, GI disturbances, and emesis. But it does not have an impact on the nicotinic acetylcholine receptors. Atropine doesn't interact with those voltage-gated ionotropic receptors, so atropine has no effect on the muscle paralysis, muscle cramps, tachycardia symptoms associated with organophosphate poisoning. Now, atropine may be given before decontamination in severe poisoning events in patients who are presenting with those sludge toxidrome symptoms, but more often than not, you will try and do decontamination before atropine is administered. Atropine is administered intravenously every 5 minutes as necessary until the sludge symptoms lessen, and the patient is then described as being atropinized. Now, a 2012 study demonstrated that mortality rates are reduced in organophosphate poisoning when atropine doses are doubled, initially starting at just 2 milligrams every 5 minutes until atropinized. So you start with 2 milligrams, you wait 5 minutes, and then you give 4. You wait 5 minutes, and then you give 8 milligrams. You wait 5 minutes, and then you give 16 milligrams. And you keep doing that until the patient has been atropinized, and you see a lessening of those sludge symptoms. That salivation, lacrimation, urination, defecation, GI disturbances, and emesis. Atropine serves as a treatment for poisoning by organophosphate pesticides, as well as these nerve agents such as sarin, VX, and Novichok. So likely was the administered treatment for both the Skripals and Nick Bailey. Oxime therapies act to directly reverse the cause of organophosphate or nerve agent poisoning. And examples include pralidoxim and obidoxim. After binding, the phosphate radical from the organophosphate actually binds firmly to the active site of the acetylcholine esterase enzyme, the enzyme responsible for breaking down acetylcholine in the synapses and ultimately then preventing uncontrolled, prolonged signaling from cholinergic receptors. This results in the formation of an inactive phosphorylated acetylcholine enzyme, and because of that phosphorylated active site, it's unable now to break down acetylcholine, and so we end up with the nicotinic and muscarinic acetylcholine receptor manifestations, because this enzyme is no longer able to break down acetylcholine in the synapse, and we end up with prolonged and continued signaling from these cholinergic receptors in the nerves and the neuromuscular junction. Oxim drugs, such as obidoxim, reactivate the acetylcholine esterase enzymes by binding to the organophosphate molecule, which has been stuck on to the active site of acetylcholine esterase from the organophosphate. Oxim drugs form a more stable complex. They bind to that phosphate ion, and the phosphate ion binds more tightly to the oxim drug than it does to the acetylcholine esterase. And so that phosphate radical is removed from the active site of acetylcholine esterase, and that enzyme is then regenerated. The acetylcholine esterase is no longer phosphorylated and is able to start breaking down the acetylcholine in the synapse and begin to reverse the muscarinic and nicotinic manifestations of organophosphate poisoning, as it's no longer bound to phosphate. Now, acetylcholine esterase cannot remove that phosphate group itself, which is why it is irreversible, but the addition of oxims allow for the regeneration of that enzyme and start breaking down acetylcholine. Oxims themselves require regular administration to patients poisoned by organophosphates or nerve agents. And when given as a monotherapy, so mono referring to one, so when given on their own, the following regime is advised. A high loading dose, where essentially you inject a lot of the drug very quickly to get it into the circulation, is administered via IV or intravenous administration. The reason we give it obviously by intravenous rather than via oral administration is intravenous goes direct into the circulatory system, and this really is a race against time in these poisoning events. So intravenous administration straight into the blood supply, that drug can then start getting to the nerve terminals, start interacting with the acetylcholine esterase in the synapses, removing those phosphate groups from the active site of acetylcholine esterase, and allow the enzyme to start breaking down acetylcholine and preventing the prolonged and sustained activation of muscarinic and nicotinic acetylcholine receptors. This will be followed by a continuous infusion of the oxim drugs such as pralidoxim at 8 milligrams per kilogram of body weight every hour, and this will continue for several days. Obidoxim has a very similar method of administration, intravenous with a high dose at 4 milligrams per kilogram over a course of about 20 minutes, and followed by a continuous infusion of 0.5 milligrams per kilogram every hour, and again continue that treatment with oxim drugs for several days until all of the acetylcholine esterase is regenerated and can start breaking down the acetylcholine in the synapses again. Now, oxims don't need to be administered on their own, and in fact the recommendations is to administer them in a combinational therapy approach. Now, the combinational therapy approach includes the auto-ejectors such as ComboPen, and this includes atropine, the muscarinic acetylcholine receptor antagonist, pralidoxim, which is an oxim for the acetylcholine esterase regeneration, and avaxifen. And avaxifen is metabolized by enzymes in the blood to give the active form of the drug diazepam, and that is the third component of the treatment regime for organophosphate poisoning. One important note that I want to include here is that what we see is the atropine, which is a muscarinic acetylcholine receptor antagonist, has no effect on the nicotinic manifestations of the organophosphate poisoning. It is the oxim drugs, such as pralidoxim or obidoxim, which then can affect the nicotinic impact of organophosphate poisoning. So that's why these combinational therapies are really important. So what is the point of adding in diazepam or the azathioprine to this combinational therapy? Drugs such as diazepam are used in the treatment of convulsions, which we see in patients with organophosphate or nerve agent poisoning, as well as a number of other drug overdoses. So diazepam actually forms a major part of a lot of our patient management following poisoning events. In the case of organophosphate poisoning or nerve agent poisoning, diazepam is actually advised even in the absence of convulsions, as it decreases agitation and other central nervous system symptoms. You will recall from the discussions that we had in the tutorial for this module, as well as lecture content from the Introduction to Toxicology module, that diazepam acts on GABAergic neurons, but we'll cover this in a bit more detail in our clinical toxicology portion of the module. Often, we will begin treating patients with organophosphate poisoning before we have a confirmatory test, and this is due to often treating the patient's presentation and in line with their toxidrome. So this increased salivation, lacrimation, urination, defecation, GI disturbances, and emesis, this sludge toxidrome. In saying that, we can conduct a number of confirmatory tests in order to confirm whether that patient has been exposed to organophosphates or nerve agents. And we have two different tests which can be conducted. The atropine challenge test, also known as the atropine therapeutic trial, or the cholinesterase activity test. Both of these will allow us to determine whether the patient has been exposed to organophosphates and what the actual treatment regimes should continue to be. In the atropine challenge test, the baseline heart rate of the patient is recorded. We then administer 1 milligram of atropine via intravenous administration, and the patient heart rate is continued to be monitored. If the patient's heart rate then increases by more than 20% from its baseline, the test is considered positive and that they're responding to atropine therapy, indicating that there's clearly an issue with the muscarinic acetylcholine receptors. All patients with a positive atropine challenge test will receive atropine as a treatment regime until they're atropinized. Not only can we test for patients with the atropine trial challenge, we can then measure cholinesterase activity directly. And this is done to confirm previous exposure to organophosphates or nerve agents, but the turnaround time is so long, between 7 and 28 days, that it's not used to dictate clinical treatment. It's used to actually evaluate whether that patient has been exposed and whether the treatments administered were correct. The acetylcholinesterase enzyme is actually very stable with a half-life of around about 3 months, and so we can conduct a cholinesterase activity test in order to work out whether a patient has been exposed to organophosphate poisoning for a number of months prior. A blood sample is taken and the amount of acetylcholine in the blood is directly measured, and this allows us to tell whether that enzyme has been exposed to acetylcholinesterase or nerve agents for previously up to a number of months. Now that takes a very long time, as I say, between 7 and 28 days, so spectrophotometric testing is much more rapid and much cheaper than the cholinesterase activity testing. And this is increasingly being used in developing countries because these are the countries which are at most risk of organophosphate poisoning, where it's much more rural. Organophosphates are kept as insecticides and pesticides, and there is accidental exposure to organophosphates or deliberate consumption of organophosphates due to suicidal ideation. As a result, cheap and rapid testing for organophosphate poisoning is required, and there has been development of this photometric testing known as the Ellman assay. The Ellman assay works by indirectly measuring the hydrolysis or breakdown of acetylcholine. When acetylcholine is metabolized by acetylcholinesterase, it generates thiolcholine from the reaction. And this thiolcholine can be measured by the addition of Ellman's reagent, DTNB. DTNB reacts with thiolcholine to produce TNB, which is yellow and can be detected at 412 nanometers. If there is little TNB absorbed at 412 nanometers, then there is little acetylcholine metabolism because the DTNB is not able to react with thiolcholine because there is little thiolcholine being produced from acetylcholine, meaning that there is little activity of acetylcholine esterase. This then allows us to determine whether acetylcholine esterase activity is being inhibited and whether patients have been exposed to organophosphates or nerve agents in a much more rapid testing way rather than the cholinesterase activity testing, which can take anything up to 7 to 28 days. The exact mechanism and methods of detection used to identify Novichok in the Skripals and Nick Bailey by the Organization for the Prohibition of Chemical Weapons has remained a closely guarded secret. They haven't actually announced how they determined that Novichok agents were the result of the poisoning event in Nick Bailey and the Skripals during the Salisbury poisoning. Now, a Freedom of Information request to the Home Office was made and asking a number of questions. Namely, the name of the test used to establish the Novichok poisoning of the Skripals, the set of symptoms suffered by the Skripals, and the name of research papers identifying how a sample of Novichok can be analysed. Interestingly, the Home Office has rejected this request as information can be withheld from disclosure for the purposes of safeguarding national security. And this makes sense. Essentially, the Home Office does not want to announce how Novichok was determined to have been the root poisoning cause for the Skripals and Nick Bailey, because then new compounds can be made which would avoid those detection mechanisms, to circumvent those detection mechanisms and try and make a more lethal and more deadly chemical weapon. As a result then, in the interest of national security, the Home Office has not announced how the Novichok agents were determined to be the root poisoning event of the Skripals. All we can do is work under the assumption that the root of elucidating mechanisms of organophosphate poisonings and other nerve agents will be very similar to that used in the Salisbury poisonings. Interestingly, before the Salisbury poisoning attempt in 2018, a 2016 study demonstrated the utilization of gas or liquid chromatography coupled with mass spec, so GCMS or LCMS, to identify Novichok agents. And in this study, the authors state that we need to have the available spectra for these agents in the event of any potential use of those in chemical warfare. And GCMS and LCMS are actually widely used to analyze chemical warfare agents, and the study also utilized nuclear magnetic resonance imaging in order to determine the spectra of these Novichok agents. The generated spectra from the study were provided to the Organization for the Prohibition of Chemical Weapons for verification activities, and so this is a likely route for how the organization determined that Novichok was the poisoning agent used in the Salisbury poisoning against the Skripals. However, as I say, due to the issues of national security, the exact mechanisms of detection of Novichok have not been released to the general public and remain a closely guarded secret in the interest of national security. And that brings us to the end of today's lecture, leaving you on a tantalizing but unknown bit of information regarding detection of Novichok and related nerve agents. In today's lecture, we have discussed the general principles of toxicology of organophosphate nerve agents and management of patients following exposure to these agents. We've also briefly discussed some of the methods of detection and confirmation of nerve agents used in chemical attacks. And so you should now be able to compare and contrast the mechanisms of toxicity of these agents, as well as describe and evaluate the different treatment options following nerve agent exposure and some of the methodology that we can use to detect exposure to nerve agents. There is a number of resources that I have placed on Canvas, which you are more than welcome to review to help consolidate your knowledge and understanding of this lecture, as well as if you're just interested in the broader story surrounding the Skripal's poisoning event in Salisbury or general organophosphate poisoning. I hope you've enjoyed today's lecture, and as always, do get in touch if you have any questions, either via email or come along to the drop-in sessions on a Monday afternoon. That's everything I have for you guys today, and this is the only lecture you have for the Advances in Toxicology module this week. So do take this time to work on your essay submissions for Dr. Greergas on the forensic toxicology portion of this module. Next week, as I say, the clinical toxicology lectures will be released en masse. All of them will be released in one go, and you can work through this in your own time. Do get in touch if you have any questions. Stay safe, and I will see you all very soon. Bye for now.